Hello, this is Edward Halpern, and welcome back to Touro University and New York Medical College's COVID-19 webinars. It's webinar number 22. We are at this for over 3 years, trying to bring you the most up-to-date information on the pandemic, both to help you who are healthcare practitioners take care of your patients, and those of you who are interested citizens and patients to take care of yourself and your family. As always, we've got a collection of experts to chat with you today, and you're gonna see a group of your old friends this time, people who have been on previous webinars. We're gonna start on today's program with a panel discussion about the new bivalent COVID-19 booster shot. Our panelists are going to tell us what it is, who should get it, and when you should get it. And then we're going to hear from Dr. Solomon Amar, who's going to teach us all about monitoring of wastewater to assess the presence of COVID-19 and polio in a population. I bet many of you have been reading about wastewater analysis to look for the prevalence of the virus. He's going to educate us on the topic. The director of the Center for Disease Control, Dr. Walensky, recently made an announcement that she thinks one of the lessons of the pandemic is that the CDC needs a major restructuring or reform. Well, the dean of our School of Health Sciences and Practice, a former officer of the CDC, Dr. Robert Amler, is going to join us in today's webinar to tell us his take on the proposed reform of the CDC. He's going to tell us what the CDC is, what it does, and what a restructuring might mean for all of us. And our last platform speaker will be Dr. Mille Etienne. Dr. Etienne has been with us many times before. He's a neurologist, and he practices in Rockland County, New York. And I'm sure many of you have read about the case of polio in Rockland County. It's been a long time, a very long time, since most Americans have dealt with polio. It's going to tell us what it is, what causes it, why did it reappear, and what we might need to do about polio in the community. Then Dr. Alan Kadish, the president of Touro University, will be here to moderate our question and answer session. So, as I always say throughout these webinars, if you have a question for our panelists, type it in the Q&A box on your computer screen, and we'll get to as many of them as we can in the Q&A part of the program. For those of you seeking continuing medical education credit, you will see the instructions appear on screen intermittently between our speakers with my voice walking you through how to get your CME credit. Thanks for joining us, and let's get on with the program. Hello, this is Dr. Edward Halpern, your host, back to not only be your host for the webinar, but your host for today's panel discussion. Now, those of you who are relative newcomers to our webinars are going to say, panel discussion? I thought they had one person talk with slides and then another person talk with slides. But those of you who've been with us for all 3 years know that throughout all of these webinars, we periodically have had panel discussions to talk about important topics, so you're accustomed to this format, although we're doing it by Zoom, not sitting live in New York, all sitting around the table like we did when we started, when we were doing these in person. But we'll do our best to achieve the same effect. We're going to talk for a little while about the new bivalent booster shot, what it is, who should get it, when you should get it. Our panelists have no conflict of interest to declare, and let's have our panelists introduce themselves to you in alphabetical order, which means we start with Dr. Bakshi.
Hi, my name is Chandrasekhar Bakshi, and I'm an associate professor in the Department of Pathology, Microbiology, and Immunology at New York Medical College, and I work with infectious diseases. Thank you.
Hi, everyone. My name is Ted Barrett. I'm a senior director of translational research and pharmacology here at Loveless Biomedical, and looking forward to participating in today's panel.
Hello, I'm Dr. Tammy Hendricks. I'm the Dean and a Professor of Pediatrics at Touro University, California, College of Osteopathic Medicine.
Hi, I'm Marissa Montecalvo. I'm a professor of medicine in the Division of Infectious Diseases here at New York Medical College, and I serve as the Medical Director of Health Services. Thank you.
Well, for those of you who've been with us for these webinars, you know we've got 4 old friends here to talk with you. And we're going to start with some really basic concepts. It's a new COVID-19 vaccine. It's a bivalent booster. So let's unpack the terminology and be sure we understand what we're talking about. Dr. Bakshi, what's bivalent about the shot? What does that mean?
The term bivalent vaccine means it contains 2 components. So the one component of the vaccine is the messenger RNA of the spike protein of the original strain of SARS-CoV-2 that initiated the pandemic. And this part of the vaccine is similar to the original vaccine that we all had. The other component of the bivalent vaccine is the messenger RNA of the spike protein of Omicron subvariant. So the composition of this new bivalent booster is designed to combat multiple variants of SARS-CoV-2 and to provide protection from severe illness. The CDC recommends bivalent vaccine to be administered as a single booster, and that's why we call it bivalent booster. And this has to be administered at least 2 months after the most recent COVID-19 vaccine. With the introduction of this booster vaccine, the old monovalent boosters are discontinued and they are no longer available to anyone except under the children of under the age of 12, as they are not yet eligible for the new bivalent booster. So that's what is meant by a bivalent booster. And thank you so much for your question.
Thank you, Dr. Bakshi. Well, Dr. Montecalvo, let's also tackle the second part of the phrase. Why do we need boosters for vaccines? I mean, I'm sure we all have post-traumatic stress when we were little kids and your mother said, today we're going to the pediatrician for the booster. So unless you were going to get bribed with a lollipop, you don't have a fond memory of a booster. Why do we do boosters?
Well, so booster is a dose after the primary series that induces immunity. So why do you need a booster, right? So I think you have to first say, what's the purpose of vaccination? So the purpose of vaccination is to produce immunity in the individual to protect you from disease. But vaccination has a secondary indirect purpose, which is if the vaccine reduces transmission, then it can create what we call quote unquote herd immunity, which is a certain level of immunity in the population that then protects others who may not be immune, such as people who aren't vaccinated or people perhaps who a vaccine doesn't take and they don't get an immune response to the vaccine. So having said that vaccines can really have 2 purposes. So do boosters, and it depends on the vaccine. So I'll just give you 2 quick examples. Think about pertussis. You receive primary vaccination in infancy. We boost every woman during pregnancy, and we boost the family members who are going to be in the immediate circle of that infant. So why is that? Well, for the pregnant woman, it increases her immunity, and that immunity is transferred to the fetus, and it creates herd immunity in that small environment of the newborn. For the other relatives, it's just all about the herd immunity for the environment because they're not really at that high risk of pertussis, but should they get it, then that would be a problem. I'll give you one other different vaccine. Look at hepatitis B vaccine. That hepatitis B is not easily transmitted person to person. You have to get a particular injury. You need a needle stick or exposure to blood or body fluids, right? So you get your primary vaccine. We don't normally boost, except if you're at high risk. So a healthcare worker is at high risk of infection. So we check antibody levels in healthcare workers. And if they're low, we give them a booster vaccine. So boosting is to maximize immunity in the individual, particularly if they're in high-risk situations, either because of exposure or in an outbreak situation. And then secondly is to can also be done to raise population immunity. In the case of the SARS-CoV-2 vaccines, the COVID vaccines, it's really protection of the individual.
Thank you, Marissa. I hope all of you who are not yet grandparents listen carefully to Marissa's example about pertussis, whooping cough. I can forewarn you, wait till your own child says, you're not coming near your own grandchild until you prove to me that you had your booster shot for pertussis. That's part of being a modern grandparent, I could now tell you. Dr. Barrett, some people have got the complaint, well, this bivalent booster hasn't been tested in large-scale human trials, but of course, we don't do large-scale human trials of the flu vaccine either. We go out and give it, and then we look to see if it's efficacious. So can you educate the audience about what kind of data are we going to look at to see if this is working or not? Dr. Bakshi told us what it is, and Dr. Montecalvo told us why it is, but how are we going to know whether it is? Is it actually working or not?
Well, exactly. So we're certainly early days in understanding whether or not this booster will end up doing what we hope it does. But there certainly is early data coming out of the now started clinical studies from both Pfizer and Moderna, which is giving some insight into what its potential efficacy will be. So we do have data now showing that the new bivalent booster produces higher levels of antibodies that target against Omicron variants versus individuals who might have received a dose of the old booster. So from that perspective, the new bivalent booster is doing exactly what we hope it is going to do. It's producing higher levels of protective neutralizing antibodies against Omicron. Now, of course, everybody's more familiar with, the percentage level of protection that a booster or vaccine is providing. Well, is it 80% protective? We're not going to know that for quite a while until we see how the infections progress with current Omicron and new variants, how much level of protection there is. We can extrapolate based on the antibody levels that are being produced by the booster that it should provide probably reasonable, relatively equivalent to old boosters in terms of the level of protection in preventing severe disease, hospitalization, and death. So I think we can be fairly confident with the limited data we have that it's going to be protective, but we just won't know specifically for a little while now.
Thank you. So Dr. Montecalvo, which adults should get it?
So once you've received primary vaccination, all adults should receive the bivalent booster, excuse me, at least 2 months after your last vaccine dose, whether that was the end of a primary series or the regular monovalent booster. I want to mention that as of October 19th, CDC actually also is now allowing or recommending that for persons who cannot take a messenger RNA vaccine or perhaps will not take it, so in those limited circumstances, you can use the Novavax vaccine, particularly for Novavax primary vaccination recipients. And that dosing interval is 6 months after the last vaccine.
Yeah, and if I could just jump in there, there's actually some early data from Novavax suggesting that a booster dose of Novavax can provide some protection against Omicron. So there's some good reason to be positive about other vaccines as well.
Dr. Hendricks, I'm sure we've got some concerned moms and dads on the webinar today. The CDC just made some new recommendations for children in COVID vaccine. So should any kids be getting the bivalent booster? And while you've got the soapbox, you think we're on the pathway that COVID vaccines is going to be part of routine childhood immunizations?
Thank you for that question. I'm actually going to address your second question first. Just recently, on October 20th, the CDC's Advisory Committee on Immunization Practices voted unanimously in favor of the decision to add the COVID-19 vaccine to the recommended immunization schedules starting in 2023. The panel said that all adults and kids older than 6 months should get the COVID vaccine and booster doses when eligible. What's important to note about that is that doesn't make the vaccine mandatory for children across the country to attend school. There have been no changes to the guidelines, and states are still able to establish their individual vaccination requirements. In terms of whether children should get the bivalent vaccine, yes, absolutely. The FDA authorized emergency use of the bivalent booster shots for children as young as 5. And just like adults, they're eligible to get that 2 months after they receive their primary series. We know that these vaccines have been effective at preventing serious illness from COVID-19, hospitalization, and death. The vaccines are life-saving. They provide stronger and longer duration of protection against future COVID-19 disease than recovering from natural infection alone. And we know that people are getting COVID-19 multiple times, especially with new strains in circulation. So these bivalent boosters certainly allow us to protect our children a little bit more against these Omicron variants.
Thank you. Let's anticipate what we usually get asked at webinars for the last 3 years at this time of year. Someone's going to write in a question, the family's getting together for Thanksgiving or Christmas or Hanukkah or New Year's, or my Uncle Sidney wants me to put down a deposit because the family's all going to go on a winter cruise to the Caribbean. And if we're all going to have the family together, how are we supposed to time these boosters for such a get together? So let's let Marissa Montecalvo go first, and then Tammy Hendricks can offer her opinion. Marissa, how are you going to time it?
Thanks. So the piece of information that we don't have the answer to is how long will the efficacy be there, right? So when the FDA reviewed the Moderna and Pfizer data in June, the laboratory data that were reviewed were at 29 days post the bivalent vaccine. But what you want to know is how long is this going to be protective, either with laboratory evidence or with clinical evidence? And neither of that is current. Neither of those two pieces of data are currently available. However, let's assume that based upon what we've seen previously, that we should get a good 4 to 6 months out of another dose, right? So that's what I'm hoping. And given that, I'm leaning toward vaccination in November. I mean, I'm definitely getting vaccinated, but I'm waiting until November to do that in preparation, both for family activities as well as duration through the winter where we're all indoors. And in terms of, family get-togethers, obviously the winter is the winter, but I think for vacations, I don't think cruises are a great idea. It's, it's still a very closed environment and a mechanism, an environment for transmission. And I would put in a vote for outdoor activities on vacations.
Okay, Dr. Hendricks, Dr. Montecalvo says sell your stock short in the cruise lines, but
I agree. I certainly am not looking to jump on a cruise anytime in the near future. Certainly the outdoor activities continue to be some of the safer in terms of disease risk mitigation. And I completely agree with her as well in terms of how long we're expecting these bivalent booster efficacy to last. It's a little bit of a guessing game at this point. Hopefully anywhere from 3 to 5 months, certainly. And the only other thing that I would add is ideally getting that immunization a couple weeks prior to the event, so you have time to build up your immunity before you are doing those big family gatherings and outings.
thank you. Dr. Barrett, let's wrap up with some crystal ball gazing. Do you think we're all in line for annual or semi-annual booster shots for COVID? And will they always continue to be shots, or do you think we're going to be invited to sniff some vaccines in the future with nasal routes of administration?
Yeah, there's a lot to consider there in terms of certainly, I think ultimately we'll probably end up there with some type of biannual or annual vaccination as the recommendation. We're certainly trying to fight through vaccine fatigue right now. So hopefully a lot of people will still get the current booster. But I hope we get there. We still seem to be kind of in this phase of chasing waves and chasing variants. We don't seem to have a lot of seasonality with COVID as of yet, but hopefully we'll get there as kind of immunity in the community develops over time. Thinking long term, there are at least 12 different intranasal vaccines currently under development. 4 of them have reached phase 3 clinical trials. So we may get there. What I think for the intranasal as well as other boosters, I think what we really need to start looking at, and hopefully we'll get there, is a pan booster, which isn't really targeting a specific variant, but targeting conserved regions of the SARS virus that these boosters we won't have to be chasing variants anymore. So hopefully, fingers crossed, we'll get there. Certainly a lot of companies are working towards an intranasal vaccine that's going to provide longer durability of protection. So let's all hope that we can get there.
Thank you, Dr. Barrett, and to all our panelists. Remember, if you have a question for any of our panelists, go ahead and type it in the Q&A box on your computer screen, and we'll get to as many of them as we can during the question and answer part of our program later in today's webinar. And let's continue on with our program with our next speaker. Thanks to all our panelists. Hello, this is your host again, Dr. Edward Halperin, with information for those of you who want to get your continuing medical education credit. As always, we've got 3 ways for you to get your credit. You can text the code 91SILD, all in capitals, to phone number 828-295-1144. If you send that text message, you'll get a response back with instructions as to how to fill out your satisfaction questionnaire and how to get your CME credit. If you don't like that technique, go to www.eeds.com, click the sign-in button, put in that same 91 SLID code, and once again, it'll give you directions as to how to fill out your satisfaction questionnaire and how to get your CME credit. And if you're the high-tech person, then go ahead and take your cell phone with your QR reader and click on that funny-looking chess checkerboard, and it'll take you to the website to do the questionnaire and get your credit. In all cases, you're going to have to get your CME credit before you go trick-or-treating, because if you wait till you go trick-or-treating, they will have expired. So you want to get it by noon on Monday, October 31st. Remember to go ahead and put any questions for our panelists in the Q&A box on the bottom of the screen, and let's get back to our program.
Hello, my name is Salman Amar. I'm professor of pharmacology, pathology, microbiology, and immunology at New York Medical College. The title of my presentation today is Wastewater Analysis to Assess for the Presence of COVID-19 and polioviruses in Community Surveillance. I have no conflict of interest to disclose. The main ways that coronaviruses are transmitted into wastewater are through human waste, used masks, and recreational activity. A little bit of the wastewater that is reused for residual solids can be also in landfill a concern for potential transmission. Rest assured that all this wastewater is being given into a treatment plant that is going to be eliminating the waste and keeping and filtering for disinfection and inactivation or any viruses, bacteria, or parasite present into the water and providing the population with clean and drinkable water. When it comes to understanding this concept of using wastewater as a potential sample for analysis of what we call point prevalence of emergence of infection, a population served by sewage system consists of, as an example, especially now in COVID-19, of unreported infection and reported infection among different individuals. Infected individuals excrete, in this case of COVID-19, the virus into the stool, urine, and respiratory secretion, as well as in the saliva. And now a sample from the sewer is interesting to be used as a tool for the analysis of the presence of COVID-19 into the sewer. Briefly, the sample is being analyzed, taken, extracted, reconstructed, and concentrated for COVID-19, and the RNA is now going to be extracted and quantified, but what we call digital PCR. Quantitative interpretation of COVID-19 gene copy depends on multiple of the methodology, but most importantly, on the normalization of human fecal fraction of the wastewater sample. What's interesting to notice is that there is a linear correlation between COVID-19 prevalence and its presence into the sewer, making the wastewater an important tool for the evaluation, the monitoring, and the surveillance of the emergence in point prevalence of COVID-19. Here, another description of wastewater sample collection at the treatment plant, providing samples for filtration and ultrafiltration. Interestingly, there is, after RNA extraction, generation of a next generation sequencing. Most importantly, this sequencing is evaluated against a sophisticated bioinformatic platform for the evaluation and the determination of the mutation that you've seen in the news, and most importantly, for variant detection and monitoring. So this wastewater surveillance is a novel and early warning tool to detect the population-wide transmission of COVID-19 as well as other threats, health stress. A wastewater sample can be used to monitor a community-level transmission of hundreds of millions of samples of people. When the virus is found in the wastewater, surveillance can detect the presence of SARS-CoV-2 for both symptomatic and asymptomatic individuals. And finally, wastewater surveillance can detect the virus in the wastewater as many as 3 to 7 days before we can see an increase of percentage of positive cases and people being hospitalized. It's an interesting, useful tool for predicting the rise of case into a community. We've been very fortunate to be selected by the New York State Department of Health to be one of the 5 centers that are going to be constantly monitoring through the wastewater, the distribution and the prevalence of COVID-19 within the state. And hopefully this process of monitoring will include additional infection agent. As you can see, five centers have been selected, among them New York Medical College, led by Dr. Mopi Devi here at the New York Medical College Genomic Center. In a nutshell, we receive 40 samples. Each center will receive 40 samples that are analyzed through a very sophisticated platform. And as a result of that, a sequencing data is going to be produced, loaded onto an environment called the SUNY environment for generation of a BAM file that is now tested against a bioinformatic platform. All these files are going to be transmitted to CDC, and CDC will make them available to the public. I'd like to spend a few minutes onto the recent paralytic poliomyelitis case study, a reemergence. As we know, poliovirus is a non-enveloped positive sense single-stranded RNA virus. During infection, the virus is excreted in the human gut. Most polio virus infections are asymptomatic. Patient can develop poliomyelitis. 1 out of 1,900 will have a viremia and resulting into a potential residual paralysis. Since the live oral polio vaccine was introduced in many industrial countries in 1960, polio epidemics had been completely controlled. And the WHO in 1988 resolved to eradicate polio by launching a global polio eradication initiative. In 1994, United States was completely considered polio-free until 2005, where another case was observed in the United States as a vaccine-derived polio type 1 in 2005. And more recently, in July 18, 2022, the New York State Department of Health notified the CDC of a detection of polio virus, this time type 2, in stool samples from an unvaccinated immunocompetent young adult from Rockland County. This county, including the Orange County, was now analyzed using waste samples. And for the little story, the patient was hospitalized for a possible acute flaccid myelitis. Vaccine-derived poliovirus polio type 2 was detected in stool samples. And as we know, the Sabin live type 2 poliovirus, which is the variant that we have, resistant variant that we have currently, have been detected into the wastewater of the patient county residents, including the Orange County, for 25 days before, up until 40 days after the patient symptom onset. 260 waste samples have been analyzed. Out of them, 8% yielded positive poliovirus using this methodology of RT-PCR and partial genome sequencing. Not all the infected individuals turn into a poliomyelitis. As a result of that, this methodology at present is an important concept that if we want to continue the surveillance, not only of COVID-19, but also of other infective agents. At present, the origin of this vaccine-derived poliovirus detected in the patient's stool remains completely unknown. And given the fact that the patient has not traveled internationally, potential exposure period detection of the vaccine-derived poliovirus in the patient's stool indicate a chain of transmission that remain within the United States, originating from a person who received a type 2 containing oral polio vaccine abroad, element of a vaccine that we don't use anymore. In conclusion, I would say that wastewater surveillance is important to observe the emergence and circulation of new variant of COVID-19, but also in poliovirus as well as other microorganisms. Understood allows the understanding of the disease and the transmission dynamics, observe the vaccination efficacy to variants of concern, and is efficient on a population sample, given that the waste sample comes from a geographic area and allowing high resolution of surveillance. Thank you very much for your attention.
Hello again, this is your host, Dr. Edward Halpern, hoping some of you will consider giving back to New York Medical College. Programs like you're watching today and our virology research programs take time, effort, and money. We hope you'll consider a tax-deductible gift to help offset our costs. Great things are happening here at New York Medical College. We hope you'll be a part of it. If you'd like to make a gift by phone, dial 914-594-2720. And like we say, operators are standing by to take your credit card information for a charitable donation for our COVID-19 education and research programs, or go online to www.nymc.edu/give to do it all hands-free on the computer without having to talk to a person. And for those of you who believe in ink and pens, we'd be more than happy to receive your check made out to New York Medical College. Put in the memo line on your check, COVID-19 webinar support, and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us during these challenging times. Stay safe and healthy. Please consider writing a question for one of our panelists in the Q&A box as the program continues. We'll get to as many as possible. And now let's get back to our program.
What is the CDC? What's its role? And must we always obey? I'm Dr. Robert Ambler, and I have no current conflicts to disclose, but I was a CDC physician for more than 20 years. CDC has had the same purpose since 1942, when it was founded by Dr. Joseph Mountain, pictured in the upper left in his uniform. CDC's mission evolved from originally just malaria control for the Department of Defense to everything else. As the Communicable Disease Center in the 1950s and early 60s, evolving to the Centers for Disease Control, the same CDC abbreviation, and more recently, Center for Disease Control and Prevention, still CDC. And originally 400 employees and staff grew to more than 50,000 cumulative who have worked in and out of the CDC over the last 80 years. Although the mission and values have grown, they have not changed. The CDC is still about disease control and prevention. Its focus is science-based, but also practice-based. And there's always been an emphasis in its culture on professional humility. Everyone always says, don't toot your own horn. Public health is, after all, a collaborative specialty of medicine. And let's remember that Mother Nature gives up her secrets grudgingly and just one at a time. So there's no need to toot our own horn. Because of that, CDC has worked in partnerships with state health departments, worldwide ministers of health across the globe, and well beyond headquarters in Atlanta, which you can see pictured on the left over the US map. The point is that being based in Atlanta, which comes from the history of malaria control in the Southeast, has actually kept CDC a bit distant from the rest of the federal government based in the Washington area. And those of us at CDC have always felt that gave us something of a buffer or a cushion from some of the political winds that frequently sweep across the Potomac among the different agencies that are based in DC. And CDC has always been very cognizant of the federalism governance model. After all, the US Constitution does not contain the words health, disease, or medicine in its language. So CDC usually requires a state's invitation before becoming involved in any kind of health investigation or public health action. And CDC's typical role is advisory. And CDC today is well beyond infectious disease, dealing with chronic diseases, birth defects, disability, obesity, injury control, workplace hazards, environmental health, even bioterrorism preparedness. Every week for the last 60, this report goes out with the latest data in tabular format for everyone to read and review, plus a couple of analyses published as brief articles that are intensively peer-reviewed internally before they are approved for release. CDC's accomplishments are extensive, but they are certainly not exclusive to CDC. And again, that's a reminder that public health intrinsically is a collaborative endeavor. CDC launched numerous immunization initiatives, and vaccination rates are way up. Smallpox was eradicated. Childhood infections have been decimated. CDC launched under Dr. Mountain, the founder, the Framingham study in 1947, and much follow-up of results of the Framingham study have led to risky health behaviors down in the United States as well as worldwide. Surgeon General reports on tobacco, along again with many health promotion campaigns, have resulted in tobacco use way down. Work with the Department of Transportation has led to motor vehicle fatalities going down. Work with EPA and OSHA have led to increased environmental and worksite safety. And even HIV and AIDS fatalities have come down. And besides these initiatives, a long list of accomplishments in combating a long list of infections, partially shown here. And again, not exclusive to CDC, the childhood infections shown on the left, some of which also, of course, affect adults. And on the right, dengue, West Nile virus, Ebola, Zika, E. coli, meningitis, the hepatitis, and the various forms of flu. And what have I left out? Well, this webinar is about COVID-19, and obviously CDC has played a big role in that conquest of COVID. But the same complexity that we all faced during these last few years have also challenged CDC, with recommendations going out over time amid many studies and many differing opinions that have been formed as more information has come out about this terrible virus. And no one has been scot-free from criticism as challenges were faced by CDC with respect to testing options, face covering options, distancing options, vaccination decisions. And gee, has anybody even seen a hand sanitizer recently? The one recommendation that has remained undisturbed is everyone still agrees, if you are sick, you must test and you must stay home. But this messaging has been complex and sometimes seems contradictory. The result has been a clear erosion of public trust in CDC, which recently was acknowledged by the current CDC director, Dr. Rochelle Walensky. This quote from the New York Times from a couple of months ago. You can see on the graph the decline in public trust in CDC from April of 2020 down to the beginning of this current calendar year based on reporting from multiple media sources. So CDC trust went down from almost 90% to between 40 and 50%, basically a drop of 1/2, a drop of 50%. But interestingly, notice how public trust generally in the US government is still only half as good as public trust in CDC, since it hovers at around 20% or even less. So CDC is developing a plan. It's still a plan in progress to improve its picture and its credibility with the public. And the plan is still general. No details have come out since Dr. Walensky's issuance of this general plan. Much of it very similar to the standard operating procedures CDC has used going back to the 1940s. Share the science and data faster. Translate science into practical policy. Focus communications on the American public and develop response readiness for future threats. Promoting partnerships is something CDC has done exceedingly well over the years, and it's clearly going to double down on expanding those partnerships. But let's face it, this has been confusing. All of us have been caught up in the fog of war. And let's face it, in any new crisis, society's experts must learn new facts and pronto. And at the same time, society's leaders are faced with the need to take new actions and pronto. And it's the urgency that makes it so challenging, so difficult for both groups to move forward in concert and well. Both groups must respect our different roles and reflect and choose wisely and then govern. In conclusion, this is a game of expectations, in my humble opinion. Let's all remind ourselves that CDC's role is advisory, not regulatory. We do not have to obey issuances from CDC in the majority of cases. There are a few exceptions statutorily, but CDC will proceed with evidence-based and practice-based recommendations. CDC will not always be perfect, but it is self-aware, and that's the first key step to improvement, I would say continuous improvement. And CDC is committed to improvement. And let's remember that CDC is still the place that the nation and the world turn to for advice that is based on evidence and practical considerations. And I wish all of us good health in 2023. Thank you.
Hello, this is your host again, Dr. Edward Halperin, with information for those of you who want to get your continuing medical education credit. As always, we've got 3 ways for you to get your credit. You can text the code 91SILD, all in capitals, to phone number 828-295-1144. If you send that text message, you'll get a response back with instructions as to how to fill out your satisfaction questionnaire and how to get your CME credit. If you don't like that technique, go to www.eeds.com, click the sign-in button, put in that same 91 SLID code, and once again, it'll give you directions as to how to fill out your satisfaction questionnaire and how to get your CME credit. And if you're the high-tech person, then go ahead and take your cell phone with your QR reader and click on that funny-looking chess checkerboard, and it'll take you to the website to do the questionnaire and get your credit. In all cases, you're going to have to get your CME credit before you go trick-or-treating, because if you wait till you go trick-or-treating, they will have expired. So you want to get it by noon on Monday, October 31st. Remember to go ahead and put any questions for our panelists in the Q&A box on the bottom of the screen, and let's get back to our program.
Good afternoon. I am Dr. Mil Etienne. I am Associate Professor of Neurology and Medicine at New York Medical College. Today, I will be speaking about polio, past, present, and future. I have no disclosures. By the conclusion of this talk, you should be able to answer the questions on this slide. What is polio? What causes polio? Why did polio reappear? And what do we need to do about the reappearance of polio? Polio is a human enterovirus type C species. It has a single positive strand RNA genome, and it spreads via the fecal-oral route. Polio has an incubation period of 4 to 10 days. It is considered eradicated in the United States since 1979, and the last known case in the Americas was in 1994. 90 to 95% of cases are asymptomatic. Less than 10% of cases will have mild viral symptoms, including headache, sore throat, fever, nausea, vomiting, malaise, and fatigue. It is rare to have meningitis, and about 0.1% of patients develop flaccid paralysis, which is the hallmark of poliomyelitis. The onset of motor weakness typically coincides with signs and symptoms of viral meningitis and may also include back pain, neck pain, and muscle pain. Weakness typically worsens over 2 to 3 days, and 2/3 of patients with acute flaccid paralysis do not regain their full strength. The more severe the acute weakness, the less likely they will regain their full power. This photograph shows an opened artificial respirator, commonly known as the iron lung. Patients with severe poliomyelitis in the 1950s depended on these devices to breathe after being paralyzed. This iron lung was donated to the CDC's Global Health Odyssey by the family of a patient who had suffered from polio and used this device from the late 1950s until his death in 2003. Again, the virus is spread via the fecal-oral transmission, which is followed by primary replication in the lymphatic tissues of the oropharyngeal and GI tract. The virus then spreads to systemic reticular endothelial tissue and is thought to get to the CNS by either crossing the blood-brain barrier or through retrograde axonal transport from muscle to the nerves, roots, spinal cord, and brain. Viral replication in spinal motor neurons results in cell death and paralysis of muscle fibers supplied by the affected motor neurons. The distribution and extent of weakness may vary, ranging from one muscle or group of muscles to quadriplegia and respiratory failure. Tone is reduced, and proximal muscles usually are affected more than distal muscles, and legs more than arms. Reflexes are decreased or absent, and the sensory examination is almost always normal. Weakness typically worsens over 2 to 3 days, and many patients have bulbar involvement, producing dysphagia, dysarthria, and difficulty handling secretions. It is important to rule out other causes of flaccid paralysis. This should include other enterovirus infections: West Nile virus, varicella-zoster virus, rabies, diphtheria, botulism, and Guillain-Barré syndrome. It is important to rule out these other conditions because making these diagnoses may lead to specific treatments. In light of the differential diagnosis, workup includes getting basic labs, MRI of the spine to rule out other more common causes of flaccid paralysis, EMG nerve conduction studies, which would show damage to motor neurons with sparing of the sensory pathways. Spinal fluid analysis would be consistent with viral meningitis to include an elevated protein, normal glucose, and an elevated white count with a lymphocyte predominance. You can also send off viral culture and PCR. The gold standard is isolating the virus from the stool. Treatment is primarily supportive care. Some patients may also develop a post-polio syndrome, which can occur months to years after recovery from the acute polio infection. Throughout the 1950s, polio disabled an estimated 35,000 people per year in the United States. In 1952, nearly 3,000 people had died from polio, and children in iron lungs populated wards in most hospitals. By 1994, however, the disease had been eradicated in the Western Hemisphere. This is largely due to the development of 2 vaccines. One is the Salk vaccine developed by Dr. Jonas Salk. Salk tested the vaccine on himself and his family in 1953 and a year later on 1.6 million children in Canada, Finland, and the United States. The results were announced on April 12, 1955, and Salk's inactivated polio vaccine was licensed on the same day. It is worth noting that Salk believed in an equitable distribution and access to the vaccine and did not profit from sharing the production or formulation processes. He considered the equitable access to the vaccine essential to eradicating this disease. A second vaccine was also created by Dr. Sabin. Because there was already a vaccine that worked in the US, there was less interest in testing this vaccine here. Like Salk, Sabin tested the vaccine on himself and his family, and later carried out trials in Eastern Europe, which showed the vaccine worked. The advantage of the Sabin vaccine was that it was administered orally, which made it more accessible and a better candidate for worldwide distribution. Given these effective vaccines and worldwide eradication efforts, how does one get polio these days? There are two ways. There is naturally occurring polio, also known as the wild type. The last such case in the US was in 1979, and the last case in the Americas was in 1994. Most countries no longer have the wild type polio infections. However, there were 5 cases in Afghanistan and Pakistan in 2021. The more common way to get polio these days is vaccine-related, which fall into 2 categories: vaccine-associated paralytic poliomyelitis and vaccine-derived poliomyelitis. With VAPP, the vaccine virus reversed a virulent form likely related to loss of attenuation mutation. This occurs in 1 in 2.5 million doses of vaccine and is more common in immunodeficient patients. Vaccine-derived poliomyelitis occurs when oral polio vaccine is used in regions with low immunization rates. This allows vaccine-derived polio virus to circulate in the community for long periods of time, to mutate, and acquire biologic properties similar to wild-type polio. There were over 400 cases in 2021 of circulating derived poliomyelitis type 2. VDPV type 2 is the most common cause of polio today. In June 2022, there was a confirmed case of polio virus in an unvaccinated immunocompetent adult in Rockland County. The patient was hospitalized with acute flaccid lower limb weakness. VDPV type 2 was detected in the patient's stool and in the wastewater in 5 neighboring counties. The patient had no international travel. Based on these findings, it was concluded that this patient likely got VDPV2 from someone who had been vaccinated with oral polio vaccine abroad. This is because OPV stopped being administered in the United States in 2000. So, what do we need to do about this reappearance of polio in the US? For medical providers, get familiar with polio, recognize the signs and symptoms, understand the differential diagnosis, and encourage your patients to be vaccinated. For everyone else, speak with your medical provider and local public health departments to get latest updates. Get vaccinated and encourage others to be vaccinated. Thank you.
Hello again, this is your host, Dr. Edward Halperin. I'd like to offer you a thought for those of you who are fired up with interest in public health based on these webinars or on some of the medical ethics questions we grapple with. If you're interested in some coursework or even a master's degree in public health, go to nymc.edu/COVIDPH, and you can learn all about our course offerings, certificate programs, and degree programs in these disciplines. For those of you interested in medical ethics, nymc.edu/COVIDethics for our full range of courses available online and in person about medical ethics. Perhaps you have a family member or a child interested in these disciplines, and everyone's welcome. Well, we hope you've enjoyed our panel presentations today, and now it's time for our question and answer period with our moderator, Dr. Alan Kadish. Dr. Kadish, the floor is yours.
Thank you so much, Dr. Halperin. The first question is for Dr. Barrett. Dr. Barrett, you mentioned a potential universal vaccine in the future. What does that mean? How would such a vaccine be constructed? And what are your thoughts about it?
Well, thank you for the question. Let's first start with a little bit of the basics in terms of, for the current vaccines, the goal is to generate an antibody response from the body where those antibodies will bind to specific parts of the virus, inactivating or neutralizing the virus. Now, what we've been targeting, we've probably all heard a lot about spike protein. Well, it's the part of the virus that's binding to cells in our body. And so naturally, we've been developing vaccines that bind to specific parts of that spike protein. But what we've been finding with SARS virus is that those mutate and change over time to gain an advantage against our immune system. Well, a universal vaccine, how it would be different is that we target different regions or parts of the virus that don't mutate as much. And so the viability of that vaccine would have a longer duration because the virus isn't changing so much at those regions. But why is that so difficult to do? Well, generally those regions of a virus that don't change much, you can get binding, but they don't, when the antibodies bind to those regions of the virus, they don't have a lot of neutralizing capacity. So it's really a balance of trying to find a region of the virus that you can neutralize it and have a long durability. So that's really the holy grail, is finding that sweet spot on the virus that antibodies can target. And thanks for the question.
Thank you so much, Dr. Barrett. The next question is for Dr. Bakshi. Dr. Bakshi, in a previous webinar, we talked a little bit about pets and animals getting getting COVID virus. You talked about potentially vaccination. How much of a problem has an animal vector been for this virus? And are we recommending or working on vaccination or other treatment for animals to prevent the spread to human beings?
Yeah, so this is an excellent question. Yes, I presented in our last COVID-19 webinar that SARS-CoV-2 is spreading to pets, captive animals, farm animals, and wild animals. And now there are more than 23 mammalian species that have been reported to have acquired infection from humans. So the pets, although they show the mild symptoms, but these symptoms are more severe in wild captive animals. And again, dogs and cats are routinely vaccinated against canine and feline coronaviruses. However, these vaccines do not provide any cross protection against SARS-CoV-2 or COVID-19. So definitely there is a need for the development of an animal vaccine, and there are a lot of efforts being made to develop animal vaccine. So in India and Russia, a killed vaccine is approved for use in animals. And in the USA, there is a vaccine which is based on a design similar to the human vaccine is developed. And it has shown good protective efficacy in cats and dogs and minks. And it has also been administered to a number of zoo animals all over the United States. However, at the same time, there is also a debate for the need of for animal vaccine, because as we all know that all the animal infection came from humans. So all those who are not in favor of animal vaccines, they advocate that if everyone is vaccinated, especially those who are coming in frequent contact with animals, if they are vaccinated, they will be at no more risk or will not pose a threat for the transmission of the virus to the animals. So there's a mixed reaction, but a lot of work is being directed towards developing animal vaccines, especially in mink forms, which had to be culled in Europe and in the United States. So those vaccines can protect those animals. Yes. And thank you so much for your question.
Sure. I think it's an important part of trying to get the virus under control. So I appreciate your answer. Dr. Amar, the next questions are for you. And the first question is, do we have any comparative data on wastewater infection rates between the data in Westchester and the data in other parts of the country?
Thank you for the question. Yes, CDC is compiling currently the data, and we'll have this in regard to COVID-19 pretty soon on a point prevalence, and not on a dynamic basis, but on a point prevalence. We will have the distribution of different emergence, and still some areas are at risk of developing some recurrent infection of COVID-19. So that will be an endeavor by the CDC.
Great. Then there are a couple of technical questions regarding the wastewater. One is, are there any privacy issues and any municipal approval issues that are come up in analyzing wastewater? Or because it's pooled from the entire region, are those issues less important?
Thank you. I think I didn't do a good job in explaining this whole process, probably. This is completely anonymous. It's pooled, as you said, it's a pooled data. There's no name on the wastewater. It does allow the evaluation of the prevalence at a given time point of the emergence of some infection. And this is taken into comparison with previous point prevalence data, not taken into an evaluation by itself as a unique data, but on a dynamic process, you will see and evaluate the emergence of a given pathogen into the wastewater. When it comes to municipal approval, I think the CDC has authority when there is an infection going into the country to request and to mandate municipal approval in regard to taking these charges. The CDC has done that, and we've seen that during the pandemic, where even IRB was not consulted when we needed to proceed with samples. As long as the data is completely anonymous, which is the case here, I don't see any problem.
Thank you so much. So the next questions are for Dr. Etienne. Dr. Etienne, the first question is, where is the OPV type 2 vaccine still used for polio? In what parts of the world?
Sure. Thank you for that question. In general, starting in the 1990s, most developed countries have gravitated towards the inactivated injectable form of the polio vaccine. And this is largely due to that, that low risk that I talked about of people getting the oral vaccine, the potential for the vaccine-derived polio. So the oral polio vaccine, we tend to see it used more commonly in lower income and some of the middle income countries. But the WHO does have guidelines based on per country, and particularly if a country is known to have endemic cases of polio, they recommend starting out with the oral vaccine and then a mixture of oral versus injectable, depending on the country. So it's a pretty complex to decide which ones or which country. It largely has to do with how if is polio endemic in that particular country or not.
So the next question, Dr. Etienne, is maybe sort of a skeptical one, which is you talked about the fact that there are a small handful of naturally occurring cases of polio worldwide, but a very small handful. Yet you showed 400 cases of vaccine-related polio. So why are we still vaccinating? Wouldn't we be better off not vaccinating and accepting that small handful of cases when the overwhelming majority of cases now are vaccine-related?
Yeah, so thank you very much for that question. So interestingly, that's why at the bottom of those slides, when I talked about the vaccine-derived, I put in red that people who are not vaccinated are at risk for both types, both the wild type and the vaccine-derived. So the main reason why we're seeing so few of the non-vaccine derived cases, meaning the wild type, is because so many people are actually vaccinated. So once we go towards, if we stopped vaccinating, then you'd suddenly see that surge in cases from the wild type polio, and you'd end up really with those curves similar to what we saw, those curves like we saw during COVID times, where people will start getting the polio again. Thank you very much for that question.
Sure. So the next group of questions is for Dr. Amler. So the first question, technical one, what's the relationship between the FDA and the CDC, and what are their each specific mandates, particularly as it relates to vaccines or antiviral therapy?
Well, that's a great question. Thank you. There are different missions for FDA and for CDC. And although they are all part of the nation's public health service, they approach issues like COVID and polio and other disease and health-related matters from different points of view. The FDA's job is to examine the efficacy and safety of various products, drugs, vaccines, other biologicals, and so forth, and license them or permit them on emergency use for use under a specified set of circumstances. CDC is charged with looking at the overall population health picture and making recommendations for populations, whether the general population or specific subgroups. In most cases, they will work in concert. In all cases, they communicate with each other as they develop recommendations. But what goes out from one agency and what goes out from the other will not always be identical. And it will be important to understand when there are differences, the distinction between what's recommended on a population basis and what, which would be CDC, and what is recommended, or shall we say permitted in a regulatory sense by the FDA based on science and biology, as opposed to the practice of putting these products out in populations. Thank you for the question.
Sure. So the next question is, I'll give you sort of two interrelated questions. One is, in your presentation, you seem to suggest that the report from the CDC director about what needs to be done didn't necessarily reflect radical change that needs to happen, but rather a better presentation of what the CDC is working on and what procedures are, and said that the goals remain the same, and that perhaps it's more of a, sort of public image effort than a true reform effort. So do you think real change is needed at the CDC, or are you comfortable that things are basically okay and that they were just faced with an impossible series of situations, and that the CDC director's report is just in a sense a response to the pressure rather than a desire for real change, when of course the real change hasn't happened? It's just a report saying we need to change, but there's so far been no structural change made.
Wow, so no controversy there. Thank you very much for that question. I think your question is very insightful. When a federal agency head, who is herself appointed by the president and serves at the pleasure of the president, makes a statement admitting that the agency has not been perfectly accurate or perfectly precise about some of its recommendations over the last couple of years, you're almost always going to hear a follow-up to that statement. And you can look at almost any other agency, state or federal, that this happens to. It's going to be followed by a statement saying, our mission hasn't changed. The basic nature of the agency has not changed, but we're going to look at each of these different areas, the ones that I enumerated, such as looking at evidence-based practice, focusing on the information needs of the public and so forth, and essentially saying we're going to do a better job of all these things without supplying the devil in the details that will say, this is how we're going to improve our performance. But it was remarkable that the director did make that statement, that did acknowledge mistakes that were made along the way. I would say particularly in the very early few weeks of COVID, when the testing that CDC put forth was intrinsically an imperfect test. And that prolonged the uncertainty, because unless you can tell where the disease is and where it's going, you can't make action decisions that are practical. And that was very unfortunate, but she admitted that that was the case. So I admired that she went forward and admitted that. And like you, I'm looking now 2 months later, perhaps 3 or 4 months later, to see how they're going to move about that. You know, most agencies form committees, and then the committees meet for a while to decide. Unfortunately, I have to say universities, not us, but other universities do that too. And that's how institutions respond to external. You use the word pressure. I would use the word constructive feedback. But in fact, I do believe there will be changes in the way these different mission elements are realized for the benefit of the public. Because again, the interest and the mission and the quality of the people who run this agency for so many decades have not changed. Thank you for the question.
Sure. So there's a follow-up question from another listener, which is, shouldn't there be an outside investigation? You know, isn't this too important to have the CDC investigate itself? Maybe Rob Amler should, you know, form a commission to look at this.
Thank you again for that non-controversial question. And I'll ignore the second half of the question. Thank you very much. Yes, I think that external oversight is a valuable thing for all public agencies. I've experienced it at CDC. I've experienced it in other parts of federal agencies I've worked for. And I think that is always a healthy thing. Obviously, the level of investigation, the level of pressure, these things then become the purview of our elected officials, which means our electorate. And those elements are intrinsically subjected to political winds. CDC over the years, I think, has really benefited from the buffer of being outside of Washington, D.C., and not having an almost week by week change of mandate depending on what's blowing across the Potomac at that moment in time. But the reality is, in this government structure that we live with and that we respect and love, that all expert opinion and all expert governance itself is overseen by political governance, which means ultimately the people. And that's, you know, we are not a monarchy, we're not a aristocracy in that sense. And so it's part of the governance. In the word of Walter Bagehot, who wrote about the British Constitution, there is an efficient component to government. There is also, he called it dignified component. But in order for government to work well, both parts of that, the scientific or the expert-driven part and the people or the political part have to respect each other and work together. So we should hope that we can all work together. And I hope that sufficiently dodged the harder part of your question. Thank you.
So let's switch gears for a moment to a couple of clinical questions that the audience had for you, Dr. Amler, although I'm not sure they'll be any less controversial. So one is, there were some comments made by others on the panel that they would not recommend going on a cruise. What's your feeling about cruising from a health standpoint?
Thank you for raising that. I think to the point, it was, in this case, specifically mentioning cruises. I would word it in a somewhat different way and say, and this is actually what we are practicing right now on the campus of New York Medical College. And that is, we are no longer mandating masks in your office or when you walk into your building or when you're walking around campus. You're in an airy space, and knowing our background rates of infection, we know the risk of transmission is quite low around our campus. However, and this could pertain to cruises, it could pertain to, pardon the expression, rock concerts, banquets, other, large gatherings. When you're with a large number of people consistently over periods of time, your contact rates are going to go up. and you are potentially exposed to a lot more people, a small percentage of whom could be infected, but that small percentage has a better probability of getting to you when you're with more people or in a closed confined space or in other types of events, such as a cruise ship or a large tour where you're with the same people over and over again in a fairly constricted space. So I agree that the risks of transmission go up when you're in those situations, and you balance that against your own personal situation. Just like our discussion earlier this summer about sending our kids to summer camp and other things, is are there immunocompromised people in your family that you could bring the infection home to you? Are there other reasons that you or people thinking of this activity should really avoid exposure? You haven't had your booster yet for a long time. Or maybe you just got your booster 2 days ago and you know it's not going to kick in, so to speak, for a couple more weeks. So I think it's an individual decision. And I think the comments of my colleagues earlier were simply pointing out that on a cruise ship, for example, you're going to have a lot more encounters with people who potentially could be infectious. Thanks for the question.
So thank you so much, Dr. Amler. So Dr. Montecalvo, we have a large number of questions for you, so we saved you for last. So first of all, is there any evidence that mRNA vaccines affect renal function?
That's a good question. Not that I'm aware of, but when there's a specific question like that, where someone could have had a temporal relationship occur with something, I think it really warrants speaking to the manufacturer to see what's coming through on the post-marketing surveillance data that all companies are required to have, as well as looking more closely at the VAERS data. So, offhand, not that I'm aware of, but that certainly isn't an adequate answer if someone's aware of it.
Related to that question, there were some internet messages early on about how the mRNA vaccines might affect reproductive function. More recently, there have been a couple of reports of changes in menstrual cycles. Is this something that you've seen or heard of? Are you concerned about this, or do you think it's not a serious problem?
I have not seen any scientific data that suggests that it, I would have to look, there may be studies going on, trying to look at it. I mean, there certainly are many women who have been vaccinated, and it's an interesting study to try to do. But again, I'm not aware of any data to suggest that.
So switching gears from side effects of vaccination to therapy, what's your current feeling about Paxlovid related rebound, and are you still using Paxlovid? How concerned should we be about rebound, and is there anything you have to recommend about that?
Well, rebound certainly occurs, and more often than was initially thought or presented. And I think it really has to do with the risk of the person. I mean, Paxlovid is a good drug to prevent severe manifestations of disease in persons at risk. Now, as we've said, the original study was in unvaccinated persons. There was a follow-up study from Israel that's both in vaccinated and unvaccinated persons, and there was still a benefit to the use of Paxlovid, even though the numbers were much smaller. So I think it's an individual decision. I certainly would use it as long as there's no contraindication, but I think, it really is an individual situation. I can definitely see not taking it as well.
Got it. So now a couple of specific questions about some of the things that you had talked about. At one point, you talked about for people not being able to receive mRNA vaccines. So who is that who can't get an mRNA vaccine that you would, think about other kinds of vaccines?
Right. Well, so I mentioned it. Thank you. I mentioned it in particular in relation to Novavax and the use of Novavax as a booster. So the main difference there is that Novavax has polysorbate and the messenger RNA vaccines have polyethylene glycol. So if someone knew that they had an allergy to polyethylene glycol, and they might have learned that after receipt of the vaccine, then Novavax is a potential vaccine for them. But there's a much larger group who simply do not want a messenger RNA vaccine, feeling that the technology is too new. And that's where Novavax really can fill a gap. So Novavax is the protein subunit vaccine that's in a matrix. And so you're actually administering the proteins and you're making the antibody as opposed to a messenger RNA where you get the genetic component, you're getting the RNA, but then you have to manufacture the protein yourself and make the antibody to it, right? So, so there's a difference there. And there are many people who did not want a messenger RNA vaccine. If they went and received Novavax as their primary vaccination, when 6 months later, they'll then be eligible for a booster, as opposed to CDC saying the only booster you can receive is the bivalent messenger RNA. So that's the change.
Okay. If you have a spontaneous, next question, Dr. Montecalvo, if you have a spontaneous Omicron infection, how long should you wait before getting vaccinated?
Yeah, thanks so much. I'm so glad that that's so important. And I'm so glad it was brought up. So the general guidance has not changed, which is 3 months. So there's quite a bit of data that, you have some protection, you have good protection for at least 3 months. It has to do with what the next strain is, right? So did Delta protect against Omicron? Well, does this Omicron protect against the other one? But in general, it's a 3-month window. And the people who seem to be the best protected are those who are naturally infected as well as vaccinated. So I think if you had infection, you can wait 3 months before you receive your booster.
Got it. All right, so we have time for just a couple of last questions for Dr. Bakshi. And others can weigh in on this as well. Is it true that it appears that the mutated variants of the coronavirus that causes COVID-19 are getting less virulent? And why is that?
Yeah, so actually, the SARS coronavirus 2 virus is an RNA vaccine, and RNA is an RNA virus. And RNA viruses in general are more prone to mutations because the enzyme that they use for their replication does not have that proofreading activity. But we have seen that the mutations can go in both directions because subsequently, as the variants emerged, we saw that the alpha variant, beta variant, and the delta variant, they were not only highly transmissible, they were also virulent. But with Omicron, what we are seeing that it has become more transmissible but less virulent. So depending on what type of mutations and how the virus is getting naturally selected after the mutation, it can go either ways. The virus can become more virulent or it can become less virulent. And we have seen that the transmissibility is also going up, with those mutations, especially occurring in the spike protein. Yeah, so it can go either ways.
Thank you so much
for that question.
Okay, the last question is for Dr. Barrett. Can you review, perhaps in a little bit more detail, what's different about the Novavax vaccine? And I guess the question really is, if someone's gotten doses of an mRNA vaccine, should they get Novavax for a different kind of protection, or would you recommend continuing boosters with a bivalent mRNA vaccine?
That's an excellent question. Dr. Montecalvo kind of alluded to this and described it very well, the differences between the two different vaccine and their approaches to driving antibody response in our bodies. But I'm not aware of any data to date where anybody has started doing a mix and match study, so to speak, in terms of if someone's received the mRNA vaccine and now taken the Novavax, does that give you an advantage? Certainly, there's been a lot of studies looking at the different mRNA vaccines that you can mix and match those, and those seem to give you equal protection. I haven't seen anything with the Novavax, because it is relatively new, that would suggest you get any advantage by switching.
Got it. All right. So thank you very much to everyone on the panel. Thanks for the audience. There were some phenomenal questions today. And as Dr. Amler pointed out, not all of them were easy. So I appreciate everyone participating both on the panel side and on the audience side. As we've pretty much said on every webinar, we always hope this is the last one, but unfortunately, I suspect we'll be talking again. Thanks again, and look forward to seeing you in the future. Take care.